Hello, I'm Dr. Youngjin Kim from Korea. I'm very happy to be here again with you guys all, and it's a great honor to have a live surgery at this OSTEM online meeting. Today, I will place 10 implants with lateral approach styles bone graft and GBR. To place implant well, I will use OSTEM digital guide surgery system called OneGuide. Before I start, I will briefly explain my surgery plan. This patient is a 51 years old male patient with no significant medical history. This is a photo taken at the first visit. The last month, during previous OSTEM online meeting live surgery, 9 implants were placed in the mandible and immediate loading was done. So this is a photo after provisional restoration delivery. And so before starting my live surgery, I want to talk about clinical effectiveness of OneGuide system in challenging cases, including fully dentureless patient or multiple missing cases. So let's talk about this. How can you place implant well in this challenging situation, fully dentureless case or multiple implant placement case? I think digital surgical guide can be a good solution. These are my main reasons why I'm using OneGuide system to overcome challenging cases. The first reason is this one. Virtual preoperative planning is possible. By using digital guided implant surgery system, we can design the final prosthesis on the program, just like a blueprint. Virtual mounting can be done, and also prosthetic design can be done in the virtual planning software. And also, we can make a good implant placement plan to support these final prostheses. Second reason is this one. Minimally or less invasive surgery will be possible. So as you know, when using this digital surgical guide template, sometimes planless surgery can be done. Some situation, minimal flap elevation can be done. But today, I will open the flap widely to perform lateral window approach and to perform GBR. So I think the digital guided surgery is not equal to planless surgery. Some situations, we should open the flap to perform additional surgery, including sinus surgery or GBR. So today, during my live surgery, I will show you how to use digital surgical guide template after flap elevation. The third reason is this one. Ideal positioning of implant for planned final prosthesis will be possible. So current trend of implant placement is restoration-driven implant placement. So on the virtual planning program, we can make prosthetic design first, and then we can make implant placement plan to support that final prosthesis. By placing implant in ideal position and angulation, we can minimize complication. So we can minimize biomechanical complication and we can maximize aesthetic result. And also we can solve the maintenance problem. Let's see this case. In this case, I placed 10 implants in the maxilla and 8 implants in the mandible without surgical template. Freehand implant placement was done. So catechin abutment was connected to the implant, and this is final result. Let's see the photo here. By placing implant in ideal position and angulation, I could make very good prosthesis without maintenance problem. Lateral view. So for the beginner, or sometimes, even though you guys are expert, this surgical guide template can be helpful. So today, I will place 10 implants with OneGuide template. That's my main reason why I plan digital guided surgery in this live surgery. So to use OneGuide system, CBCT and surface scanning data was merged in the planning program. Merging was done, and then prosthetic design was done. So here in the molar area, I will place 5.0 diameter TS3 implant. In the premolar, 4.0. In the canine, also 4.0. On the left side, premolar area 4.0 and molar 5.0. So this is a free OP photo in the maxilla in the occlusal view. So as I said, I will open the flap widely to perform lateral window approach and GBR. So after flap elevation, only remaining 2 central incisors can support OneGuide template. So during drilling, the surgical template can be tilted like this. Because in the posterior area, this OneGuide template will not be supported by gingiva. So to stabilize this such OneGuide template, I designed 2 anchor pins in the palatal area. So inside the OneGuide kit, we can get 3 anchor screws. So after flap elevation, I will fixate my OneGuide template with 2 anchor pins. And then some dentists may worry about the predictability of this implant because the residual bone height to the sinus floor is quite limited, around 2 millimeters. So should we do staged implant placement, or can we perform simultaneous implant placement after sinus bone grafting? Previous studies stated that residual bone height is determining factor to get successful osseointegration after sinus bone grafting. But recent studies stated that there is no relationship between implant failure and residual alveolar bone height. I agree with this research. Primary stability is most important to get successful osseointegration after sinus bone grafting. So if we can maximize primary stability by placing taper design implant, we can maximize the predictability or success rate of implant. So today I will place TS3 SA implant because TS3 has a taper design. So we can get high initial stability. So also to maximize the initial stability, undersized drilling will be done. And also TS3 SA has very good SLA surface. So with this SLA surface, we can maximize, we can accelerate osseointegration speed. So as shown in this photo, this patient presents maxillary cyst, large cyst in the left maxilla. So during sinus membrane elevation, I will try the aspiration. Because of the huge size of the cyst, the sinus membrane elevation will be difficult. So I will try aspirate the cystic content. And in the both canine and the post-premolar area, there will be a very narrow ridge. So to make appropriate bone support around the implant, canine and the post-premolar implant, I will do GBR. To make appropriate alveolar bone contour around the implant, I will use this Ossbuilder, 3-dimensionally preformed and customized titanium mesh which can be connected to the implant. As shown in this slide, Ossbuilder is a preformed titanium mesh, unlike the 2-dimensional flap type titanium mesh. No need to bend and no need to trim. Just select appropriate shape and size, and we can connect this Ossbuilder to the implant. Just like this case, I placed the implant in the canine here. So to make ideal contour of labial bone, I used SmartBuilder. By using this SmartBuilder, I could regenerate labial bone successfully with ideal contour and ideal thickness here. So to use this Ossbuilder, first we should place implant, and then to connect this Ossbuilder to the implant, anchor should be connected instead of healing abutment or cover cap. And then bone grafting should be done, and to cover the entire bone graft material, this appropriate size and shape of Ossbuilder should be selected and placed. And this Ossbuilder can be fixated with healing cap or cover cap. Today I will use healing cap because this patient will use temporary denture as a provisional restoration. So to summarize my live surgery, first lateral approach sinus membrane elevation will be done after flap elevation. And then 4 implants will be placed with the OneGuide surgical template in both canine and the post premolar area. In the molar area, I will place implant after bone grafting. And after bone grafting, 6 more implants will be placed. And then in the canine and the both canine and the post premolar area, GBR with Ossbuilder will be done. So wish me luck and enjoy watching my live surgery. Thank you. And from now, I'll start my live surgery. So first, I'll make an incision and I open the flap.
Dr. Kim, can you hear me?
Yeah.
Yes. Yeah, Dr. Kim has an incision, the crestal incision, but slightly palatally. Yeah.
And then to advance the buccal flap, I'll make a vertical incision. The distal line angle of the first central incisor.
Yes.
Okay.
Mm-hmm.
And these 2 central incisors will be extracted after implant placement.
Mm-hmm. But before the surgery, this is a central incisor very important for the guided the surgical stent.
Yeah.
Mm-hmm.
Because of adhesion between bone and periosteum, the flap elevation is so compromising.
Yeah, I see. Such in the upper arch, sometimes it's very difficult to elevation of the mucogingival flap. Yeah, and at the time the precise incision is very important. Mm-hmm.
So I will cut the periosteum again.
Yes. I see.
Yeah.
Yeah, usually in the upper arch is incision is sometimes very difficult, and the elevation of the mucoperital flap is also difficult. But clear elevation of the mucoperital flap is very important.
고개 왼쪽으로 돌려보시고요. 고개 숙여보세요. Yeah. I could expose the lateral wall of maxillary sinus, and I will make a lateral window.
Yes.
Gentle palatal flap elevation. Okay. Second picture. Okay.
Yeah, Dr. Kim has a lateral window with the straight handpiece with the round bar.
lateral wall is so thin.
Yeah, so such a smooth touch with the round bar is very important because the lateral wall is very thin. Yeah.
And then I fracture the lateral window. I will keep this lateral window in the saline. And then first, I will separate the sinus membrane along the margin of lateral window with this membrane separator.
Yeah, I see. The round such a membrane separator is very similar with the physioelectric surgery kit, but sometimes very convenient. After then, small size free elevator.
This is my routine of sinus membrane elevation from the distal and floor, and then finally anterior.
Yeah, Dr. Kim has always the more easy area is the posterior side. Posterior side more easy. We can access is very easily elevate the sinus mucosa.
Wow, sinus membrane is so thin. After initial detachment, I will use free elevator. And finally, medial wall, palatal side of maxillary sinus should be elevated, detached. So by exposing the medial wall, we can get good blood supply and bone-forming cell supply.
Yeah, I see. Dr. Kim said it's the medial side of the sinus wall is very important. Elevation of the fully of the sinus mucosa, sinus membrane is fully elevated is very good for the blood supply of the graft materials.
The sinus membrane elevation was done successfully without perforation.
Yeah, you can see the move of the sinus membrane. The patient is bleeding.
Okay. So let's move to the left side. Okay.
Yeah, good. Yeah, Dr. Kim did the successfully elevated the sinus membrane of the right side of the patient, and now is to the left side.
So
Dr. Kim has a crystal incision from the posterior side to the anterior side. And with the anterior is a vertically leading incision for the elevation of the flap.
보스미까지 준비했죠?
Dr. Kim did the incision from the posterior side first, after then to the anterior side, and the elevation of the mucopharyngeal flap from the anterior side, because of the anterior is more easy to elevate it, the sinus mucopharyngeal flap. And usually the maxilla is more difficult to elevate the mucopolysal flap. Usually the mandible is more easy to elevate the mucopolysal flap. In such a patient, the residual alveolar bone of the maxilla is uneven and sometimes very difficult to elevate the sinus mucopolysal flap.
오른쪽으로 조금만 더요. 네. 아.
You can see the maxilla, the lateral wall of the sinus wall is very thin, so sometimes the transparency of the maxillary sinus.
아. 지금 당겨봐. 디스탈 플랫. 플랫도 당겨. 네. I'll make a lateral window. 거기 오른쪽으로요.
Dr. Kim made the lateral window with the straight hand piece with the round bar. And Dr. Kim's left hand has a minuscule elevator and protection of the mucopolysal flap, and the maintain the operation field is clear. And usually the left side, the mucopolysal flap elevation and is very important for the good operation field. Very thin lateral wall of the maxillary sinus. And Dr. Kim moved the round bar, such as the brush, as a very slight contact with the lateral wall and without the pressure. Dr. Kim make a fracture of the lateral window and the store in the saline. And
Same as right side. Membrane separation.
Yeah, membrane separate with the round instrument. And this is a separation between bone and sinus membrane. Yeah, you can see the move of the sinus membrane. The patient has a bleeding. Yeah, elevate the sinus membrane from the posterior side. Usually the posterior side is more easier to elevate the sinus membrane. And the lower side, lower area, and then after the anterior side.
In the CBCT, this patient presented cystic lesion in the medial side, anterior side. So I will try the elevation. Syringe. So because of some fluctuation, elevation is quite limited. So.
Dr. Kim said this left side has a mucocele, such as the mucosal retention cyst inside of the maxillary sinus, and the aspiration with the syringe. You can see the aspirate the sinus cystic fluid, and it is
antibiotic.
yeah, very clear and clear straw like the straw fluid like the slightly yellowish.
Cystic fluid was aspirated. as the sinus membrane was elevated because of the folding effect, the small population was sealed.
Yeah, Dr. Kim said the small population because of he aspirated the content of the mucocele, so sometimes the small population will be the membrane is elevated and folded and the spontaneous the healing and with the repair.
But in this situation, as shown, this is a serous type. So this serous type is not contraindication because this is not pus.
Yes. Dr. Kim said this is cystic content is very clear and it is not pus. It means there is no impacted and it is no problem of the sinus graft.
Then I will irrigate the inside the sinus cavity with aminoglycoside antibiotic to minimize the infection after bone grafting.
Yeah, Dr. Kim said such as the antibiotics, the irrigation inside of the sinus cystic cavity.
And then I will start the drilling.
And the application of the OneGuide.
Okay. So as I said during my presentation, I will fixate this OneGuide template with 2 anchor screw. Turn it back.
And on the palatal side. Yeah, Dr. Kim have the fixation of the OneGuide surgical stents with the anchor pins, palatal side. And this is the drilling for the 2 anchor pins. To hold the surgical stents, OneGuide, and there is an anchor pin. And one's right side first, but it is not tightly, and the left side anchor pin about 80 or 90% the tightening after then. Yeah.
As Dr. Professor Kim said, even tight fixation without tilting.
Yes. Yeah. Such the tightening of the ankle pin is very important.
Good.
Because of the OneGuide stent is stability is not so good because of the only 2 teeth. So the ankle pin is very important.
Yeah, this is initial drill.
Initial drill of the right side of the canine area. And the first premolar area. And the second premolar area. And the left canine area, left upper canine. The initial drilling.
So in this situation, if you can touch the guide hole with initial drill, in case of deep implant placement case, it will be much better to use this flattening drill.
You mean such as the flattening drill for the preparation of the drilling site. This is the flattening drill for the preparation of the drilling site of the canine area. Dr. Kim used the flattening drill is the sharp edge of the alveolar bone.
Yeah, right.
Yes. Initial drill.
After using flattening drill, I could get full depth drilling.
Yes. And the first premolar site.
So I will use flattening drill in first premolar area.
Dr. Kim said such as the alveolar bone height is not flat. At the time, the initial drill is not fully drilled. So he used the flattening drill before the initial drill. Flattening of the alveolar bone.
The molar area, wide hole. I will use only initial drill in the molar area.
Yes. Yeah, he did the initial drill, but the molar area is drill hole is more wide, so the initial drill is different size. He said only the molar area is the only initial drill, and
The
positioning
canine.
of the implant area.
3.5 by 11.5 in K9.
Yeah, this drill is the diameter is 3.5 and the drill length is 11.5.
오른쪽으로 돌려주실까요? In premolar area, the length will be 10, 3.5 by 10.
Yeah, the premolar area, both sides is the drill size diameter is 3.5, drill length is 10 millimeter. This is 10 millimeter drill. The first premolar and second premolar.
And the maxilla, the bone is so soft, so I will do undersized drilling.
Yes, Dr. Kim prepared, have a plan. The final diameter of the fixture is 4.80, but the bone is not so good. So the final drill is only the 3.5 diameter on the drilling. Yeah. And the final drill is 3.5, and after then installation of the implant, TS3 implant. TS3 implant of the right canine site. This TS3 fixture is no mount, and with the fixture driver.
And depth control.
Depth
is
control,
on.
yeah.
Wide 같은데.
Yeah, Dr. Kim have drill depth is control is hand wrench. Hand wrench have depth control of the right canine. This implant is a diameter 4.0 and the length is 11.5.
Depth control was done. And then I place one more implant. 오른쪽으로요.
And the left side, the canine, 4.0 diameter of the implant with the length is 11.5 and the TS3 implant.
Because of interference of central incisor and
Yeah, because of there is a central incisor interference, so the drill extension. Yeah, drill extension of the.
I think because of very thin 아니잖아. I do depth control with the fixture driver.
Yeah, final depth control is a hand wrench, and the yellow.
I think the implant was displaced.
Yes.
Yeah.
Yeah, very thin alveolar bone, and the implant is.
So I will place implant manually.
Yes, I see. The
4.0씩 하나 더.
left canine area is alveolar bone is very thin, so sometimes the implant is slipped, and so the
빼자.
next
박스.
manually. Yeah, he removed the anchor pin because of the left canine area is alveolar bone is very thin. So the implant fixture is displaced, very thin area. So he removed the anchor pins.
Yeah, sometimes we may experience this situation because dental technician cannot expect the implant surgery. Okay. Let's see. Yeah. I think this OneGuide is quite useful to make the initial drilling at the ideal position.
Yes. Yeah, Dr. Kim said even though the slipping of the slip of the implant fixture, but the OneGuide is a very benefit is the drilling point. Initial drilling point is very important for the exact good position.
So usually when placing implant in the knife edge, the side cutting drill should be used. Unfortunately, OneGuide digital guide kit has no side cutting drill. So because of very strong palatal or lingual bone, the drill or implant can be displaced or push it out to the buccal side.
Yeah. Yeah, Dr. Kim said usually the palatal side is bone is very hard, and the labial side is very thin and very soft. Sometimes, such as the implant is slip and the very thin area. And he did the lateral side cutting drill with the more palatally positioning.
4.0 13조. Yeah. To get appropriate initial stability, I will increase the implant length.
Yeah, his plan is implant the length is 11.5, but for the more tight the primary stability, he did the change to the length. The implant length is 13 millimeters. Diameter is the same, but the length is more longer than planned.
By increasing the length, I could get appropriate initial stability. Okay.
Yeah, Dr. Kim changed the implant length. After then, get the primary stability, good primary stability, even though the very knife edge area. He changed the plan from the 11.5 to the 13 millimeters. And the first premolar with the 4.0 with the length is 10 millimeter implant.
Yeah. In the post premolar area, the initial stability is so good.
The primary stability is very good, first premolar area.
Okay.
Even though the thin alveolar bone.
One more 4.0 by 10 in right post premolar area.
Yeah, yes. The right premolar area is also diameter is 4.0 and the length is 10 millimeter of the TS3 implant.
맞춰 더 해드릴게요. 맞춰 더 줘.
Yeah, the patient has a slight painful, so because of the amount of the bleeding is severe, sometimes the patient has a pain, so the more inject of the lidocaine. Such as a wide incision, and after then the bleeding is slightly. After then, sometimes the local anesthetic effect is slightly decreased, so the patient is slightly painful. So the more anesthesia. And usually the lidocaine with the epinephrine, so it's helpful for the bleeding control.
So right side, the canine and post premolar implant was placed as I planned. In the molar area and including second premolar area, I will place implant after bone grafting.
Yes.
So right side.
Yeah, Dr. Kim said the second premolar area is also inside of the sinus cavity. So after the bone graft, after then placement of the implants, and you can see the movement of the sinus membrane, the patient when breathing.